If you found this helpful, consider liking the video and subscribing to support the channel. We really appreciate it. Every video we make is based on real, peer-reviewed research from NCBI, so you're getting trustworthy information backed by science, not hype. Thanks for watching. Stay sharp, stay curious, and stay healthy. Influenza, or the flu, infects up to 1 billion people globally each year. According to the World Health Organization, to 5 million of these cases result in severe illness, and 290,000 to 650,000 lead to death from respiratory complications. In the United States, during the 2022-23 season, the CDC estimated over 31 million symptomatic cases, 360,000 hospitalizations, and 21,000 deaths. While vaccines remain the first line of defense, their effectiveness fluctuates. The CDC reports seasonal flu vaccines range from 10% to 60% effective, depending on the degree of strain match in a given year. Because influenza viruses mutate rapidly, vaccines are reformulated annually using the best available surveillance data. Still, mismatches occur, leading to significantly reduced immune protection. Meanwhile, standard antiviral drugs are losing ground. Neuraminidase inhibitors, like oseltamivir, Tamiflu, and zanamivir, Relenza, block the release of viral particles from infected cells, but resistance is on the rise. By 2009, oseltamivir-resistant H1N1 strains had become dominant globally. Since then, additional resistance mutations have emerged in both seasonal and zoonotic influenza viruses. This has sparked urgent demand for new antiviral strategies. A 2024 peer-reviewed review published in the open access journal Pharmaceuticals, titled New Therapeutic Approaches to Influenza, outlines 4 innovative antiviral directions: polymerase inhibitors, monoclonal antibodies, host-targeted therapies, natural and repurposed antiviral agents. The first strategy, polymerase inhibition, targets viral replication early. The influenza virus relies on a tripartite RNA polymerase complex consisting of PA, PB1, and PB2 subunits to replicate inside human cells. Baloxavir marboxil is the first FDA-approved polymerase inhibitor. It specifically inhibits the cap-dependent endonuclease enzyme found in the PA subunit of the virus. This enzyme is essential for the cap-snatching process, where the virus steals host mRNA caps to begin its own transcription. Without it, the virus cannot produce its proteins or replicate its genome. Baloxavir is taken as a single oral dose and acts quickly. A Phase 3 trial published in the New England Journal of Medicine found baloxavir reduced viral titers by over 90% within 24 hours, while shortening symptom duration by more than 24 hours compared to placebo. It also reduced the period of contagiousness, making it valuable for both treatment and limiting spread. In contrast to oseltamivir, which requires 5 days of twice-daily dosing, baloxavir's single-dose design improves compliance. This may be particularly beneficial for high-risk groups and in outbreak or pandemic situations. However, clinical trials have observed resistance mutations at the I38 position of the PA gene. These mutations decrease baloxavir's binding efficiency and reduce its antiviral potency, especially in pediatric patients. This resistance has prompted development of next-generation polymerase inhibitors designed to target additional subunits and use dual-action mechanisms. Several are now in preclinical or early-phase clinical trials, with the goal of broader coverage against influenza A, B, and zoonotic strains. These new inhibitors may also reduce the emergence of resistance by applying pressure at multiple replication stages. Because polymerase is essential and conserved across flu strains, this class of drugs holds strong potential for seasonal use and for use against emerging pandemic strains like H5N1 or H7N9. As of 2024, polymerase inhibitors remain one of the most promising new directions in antiviral flu treatment strategy, especially when combined with other approaches. Beyond polymerase inhibitors, the second major strategy in influenza treatment is the use of monoclonal antibodies, MAbs. Monoclonal antibodies are engineered immune proteins designed to bind to specific regions on the influenza virus. Once bound, they can neutralize the virus, mark it for immune destruction, or prevent it from entering host cells. Unlike vaccines, which require time to activate immune responses, monoclonal antibodies offer immediate protection, making them ideal for high-risk individuals during outbreaks. Most MAbs target the hemagglutinin HA protein, a surface glycoprotein used by the virus to enter host cells. Traditional antibodies bind the HA head, which mutates frequently and limits long-term effectiveness. However, recent research has shifted focus to the more stable HA stem region, a highly conserved domain across multiple influenza strains. Antibodies that bind the HA stem can neutralize diverse strains, offering what researchers describe as a universal protection. A prominent candidate is NCBI-A4549A, a human monoclonal antibody targeting influenza A. In clinical studies, it demonstrated significant viral load reduction when administered intravenously within 72 hours of symptom onset. Other promising candidates include VS410 and CTP27, which are undergoing evaluation in combination therapies to increase coverage against multiple subtypes. One of the biggest advantages of MAbs is their use in post-exposure prophylaxis. In outbreaks within nursing homes or hospital settings, monoclonal antibodies can protect patients who are too immunocompromised to receive vaccines. They may also be used alongside antivirals to reduce the risk of resistance by targeting the virus through multiple mechanisms. The third strategy reviewed in the 2024 paper involves host-targeted therapies. These treatments don't act directly on the virus, but instead alter human cellular pathways to block the virus's ability to hijack host machinery. This approach is appealing because viruses mutate rapidly, but human genes are much more stable. Targeting host functions may reduce resistance risk and increase effectiveness across influenza types. One example is the use of sphingosine analogs, which modulate the immune response by altering cytokine signaling. Drugs like fingolimod have shown promise in reducing lung inflammation during severe flu. Another example is CAM-key inhibitors, which block pathways used by the virus to manipulate host metabolism and immune escape. In preclinical models, these drugs reduce disease severity and improve survival rates, even without reducing viral load directly. Additional host targets include the ERK-MAPK pathway, NF-kappa B signaling, and cholesterol trafficking proteins that are exploited by influenza during its replication cycle. Researchers are also exploring autophagy-modulating agents, which disrupt the recycling process hijacked by the virus to avoid immune detection and support replication. These therapies may be especially useful in pandemics when rapid deployment of virus-specific drugs is not feasible. However, host-targeted therapies carry higher risk for side effects since they interfere with human biology. Careful dosing and patient screening will be essential for their safe implementation. Together, monoclonal antibodies and host-targeted strategies represent powerful additions to the antiviral arsenal. Each comes with unique advantages and challenges, but when combined, they may create multi-layered defense against even the most virulent flu strains. The fourth strategy explored in the 2024 Pharmaceuticals Review focuses on natural compounds and drug repurposing as cost-effective, fast-track options for antiviral development. Unlike traditional drug pipelines, which can take over a decade, natural agents and existing medications can bypass early-phase safety trials, accelerating access to frontline treatments. Among the most studied natural antivirals is Bicolin, a flavonoid from Scutellaria bicolensis, or Chinese skullcap. It inhibits neuraminidase, a key enzyme the virus uses to spread, and reduces inflammatory cytokines like TNF-alpha and IL-6. In murine models, Bicolin reduced viral load, lung damage, and mortality. Another compound, epigallocatechin galactase, EGCG, from green tea, prevents viral entry by binding hemagglutinin. It also boosts immune response and has demonstrated synergistic effects when paired with neuraminidase inhibitors like oseltamivir. Resveratrol, the antioxidant found in red grapes and wine, inhibits replication by blocking the NF-kappa B pathway. Studies show it reduces viral protein production and may help protect lung tissue during infection. In the repurposed drug category, nitazoxanide stands out. Originally developed as an antiparasitic, it enhances interferon pathways and improves early immune detection of viral threats. Clinical trials have shown nitazoxanide shortens flu symptom duration and reduces viral shedding, even in oseltamivir-resistant strains. Favipiravir, another repurposed antiviral, was originally developed for hemorrhagic fever viruses like Ebola. It inhibits viral RNA polymerase, a mechanism shared by all influenza types. Favipiravir has shown broad-spectrum flu activity and has already been stockpiled in several countries for pandemic response. Other repurposed candidates include ivermectin, which disrupts important pathways used by the virus for nuclear entry, and statins, which reduce systemic inflammation and cytokine storms but don't act directly on the virus. The review concludes that combining natural products, repurposed pharmaceuticals, and direct-acting antivirals may yield multi-layered treatments less prone to resistance. Researchers emphasize the importance of combination strategies, especially in vulnerable groups like the elderly or immunocompromised. New trials are underway testing dual-action therapies involving polymerase inhibitors, monoclonal antibodies, and host modulators. Universal flu therapy may not rely on a single miracle drug, but rather a coordinated toolkit that treats the virus at multiple levels: replication, entry, and immune evasion, as influenza remains a global health threat. The 2024 findings give hope that new therapies could permanently lower flu severity, reduce hospital burden, and stop future pandemics before they begin. If you found this content useful, give it a like to support the channel. Subscribe for more science-backed breakthroughs, and as always, stay curious, stay healthy,